Good morning and welcome to Breakfast with Breastlink. Thank you for joining us this morning for what is sure to be an informative and exciting discussion on a range of issues concerning breast health. I'm Stephanie Landon from Breastlink and I'm your moderator today for this presentation. Before we get started, I just want to quickly go over how we're going to do the Q&A portion of this discussion. Because we want to make sure we get to all of your questions, we're going to hold questions until the end of the last presentation. However, because this is breakfast with Breastlink and not lunch or dinner with Breastlink, we are going to try to limit the Q&A portion to around 20 minutes. Just keep that in mind, and if we don't get to your question, we'll provide an email where you can still ask it and get it answered. If you'd like to ask a question, please type it into the chat box and I will read it to the appropriate doctor, again, at the end of the last presentation. And please make sure to indicate which doctor your question is for. If you have any issues or technical questions at any point, please feel free to message me. Now, I'd like to introduce our first presenter, Dr. Jason Mckellop. Dr. Mckellop is a board-certified radiologist with fellowship training in breast imaging from New York University Langone Medical Center, and he's also the medical director at Breastlink Tarzana. He has said that the culmination of his life work has been dedicated to finding small breast cancers before they grow and spread and become deadly. So I'd like to welcome Dr. Mckellop now.
Good morning, everyone, and thank you, Stephanie, for such a kind and warm introduction. My name is Jason Mckellop, and I am the Medical Director of Breast Imaging in Southern California for Beverly Radiology Medical Group and Breastlink. And this morning, I'm going to be talking about mammography and some of the current challenges that we face with mammographic screening, and then also touch on some of the new technologies that we're using to combat some of these challenges. So as a disclosure, I am a consultant for Hologic, which is a medical device company. And I wanted to start by just reviewing the objectives of this brief talk. First, I'm going to discuss some of the technology underlying breast imaging, specifically digital breast tomosynthesis, commonly known as 3D mammography. Then I'll review some of the challenges facing mammographic screening today, and then finally end with some of the new technical or technological advances that we're going to use to combat some of these challenges. So by way of a brief background, I'd like to discuss breast cancer epidemiology, or some of the statistics underlying breast cancer, just to remind everyone the importance of this disease. Now, excluding cancers of the skin, breast cancer is the most commonly diagnosed cancer among women. It's the second most common cause of cancer-related deaths. One important statistic to note is 1 in 8 women will develop breast cancer in their lifetimes. That's about 12.2% of the female population. Now, every time I see this statistic, it gives me pause, because it's really sobering for me to think that 1 in 8 women, and all of us know 8 women just in our lives personally, whether it be a family member, a loved one, or a friend. And to think that 1 in 8 women will ultimately be diagnosed with breast cancer in their lifetimes is a very sobering thought. Of those women who are diagnosed with the disease, 1 in 8, or 1 in 3 women rather, will ultimately die from the disease. So just wanted to remind everyone of the impact that breast cancer has on society at large, and how many people it actually impacts. So now I want to talk about the state of the art as it relates to imaging the breast. If any of you have been imaged or had a mammogram within the past decade, then you probably recall having an X-ray taken in 2 basic projections, one from the top down and the other from an oblique position, where you're positioned kind of in a Superman or Superwoman pose. And then the second image was taken while holding you in that uncomfortable position. Well, the positions haven't changed, but the technology acquiring those images have changed. And currently we do a 3D mammogram, or a digital breast tomosynthesis, which, as I mentioned, is the state of the art in terms of imaging the breast. And as opposed to a single projection, an arc of images is taken through the breast. And what that affords us is the ability to scan through the anatomy as we would a CT scan or an MRI. And a good analogy to make is, if you're looking at the blueprint of a home, for instance, a 2D mammogram is analogous to looking at the bird's eye view, or that 2-dimensional representation of the home, whereas a 3D mammogram, or a digital breast tomosynthesis, is like a virtual fly-through, or if you could imagine a drone flying through the home, allowing you to see the 3-dimensional features of the home, as opposed to a flat sheet of paper or the 2D projection. So this arc of images is acquired using low dose projection. And as I mentioned, this allows us to reconstruct the anatomy in a volumetric fashion. So that offers several advantages in terms of diagnosing disease, as well as ruling out benign entities. So what are some of the challenges that are facing screening mammography, or just mammography in general? Well, there are several challenges, but I'll name just a couple in this slide. Mammograms are still not 100% sensitive for detecting breast cancers. And what that means is that a cancer may in fact be present within the breast, and we simply cannot see it on the mammogram imaging study. And that's just merely a limitation of X-ray technology. It's not able to detect or allow us to visualize cancers that may in fact be within the breast. And these are so-called false negative exams. So a cancer within the breast that we're simply not able to see. Mammograms are also not 100% specific for detecting breast cancers. And in these circumstances, there are findings that may resemble breast cancer, but truly are not disease. And these are so-called false positive tests. Also a source of frustration for radiologists and patients alike, because these are the exams that we recall patients for additional workups, possible biopsies, and they ultimately turn out to be benign entities. So these are the so-called false positive exams. There are other technical challenges that face mammography. Some of them are related to the new technology that I had mentioned before, breast tomosynthesis. Because it's a more sophisticated exam, and it gives us a lot more information. It takes up a lot more space on our hard drive locally, as well as it's a lot less palatable in terms of transmitting this information over our network systems, given the large file size. Just a much more sophisticated exam with a lot more detail and a lot more imaging information. And because of this, it also takes a lot longer for radiologists to interpret because their eyes have to scan across a lot more data, if you will, or a lot more imaging information. So very time consuming and exhausting for people like me, a breast imaging radiologist. So what are some technologies or a technology that we can use to combat some of these challenges, specifically some of these technical limitations that we have? Well, there's several exciting new development within radiology and within breast imaging specifically, but in the interest of time, I'll limit it to one of the biggest and maybe more popular topics, not only within medicine, but within society at large, and that is artificial intelligence. I don't know about you, but when I think about artificial intelligence, at least outside of medicine, one company comes to mind, and that's Tesla. Tesla is now a household name. We all know it for automotive manufacturing, but it also involves itself in energy and space exploration. But the reason I think about Tesla is not so much for the batteries that it's developed in its cars or the electric motor that will ultimately usher in the end of the internal combustion engine as we know it. But I think about it as it relates to artificial intelligence because of the autopilot feature that has been a topic of controversy recently. And that's in large part because there have been some accidents, some noteworthy accidents where people have literally taken their hands off the wheel and allowed the autopilot to drive the car. And in certain circumstances, it's been shown, and it's under federal investigation currently, that the car is prone to accidents. So I think about Tesla and this autopilot feature as it relates to artificial intelligence in medicine. And although it may strike fear in a lot of people, the potential of it and the power of it is inarguable. It's something that is very powerful, and I think will offer several advantages not only in the automotive industry but also in medicine alike. Obviously, we can't put such technology in the hands of maybe reckless people like this, social media or TikTok star who was so comfortable with his autopilot that he decided to take a nap in the back seat of his car while his car was driving on the highway. Definitely gives good or new meaning to falling asleep behind the wheel. Well, artificial intelligence, as it relates to mammography, it has several advantages. It can highlight suspicious lesions on mammogram, and that's a way of improving our sensitivity for detecting disease, one of the limitations that I pointed out of mammography at the outset. It can improve practice efficiency for radiologists. Artificial intelligence has been shown to not only detect disease, but it can repopulate a work list, meaning bringing more pertinent findings to the top of a reading list for a radiologist so that diagnoses are made more accurately, not only more accurately, but more quickly. And it can do such things as assist in scheduling and staffing of patients. These are just a few examples of some of the strengths and some of the offerings of artificial intelligence within our space. And truly, it is offering a new frontier in terms of medical imaging and medicine at large. We've already begun implementing artificial intelligence into our workflow. Our Hologic systems, our new mammography platform, already has AI algorithms baked in. So it helps us distill a large volume of data into more useful and more salient images, which cuts down on the time spent on reviewing images that we would otherwise be spending. We use AI to confirm a mammogram is truly negative through a partnership with a company named Deep Health, which specifically looks into artificial intelligence, so that it gives us more confidence in making benign or negative diagnoses. And we also apply artificial intelligence to our ultrasound evaluation. And in this software by a company named Kios, can tell us whether or not something is truly suspicious or truly benign, something very helpful for mammographic imaging, mammographic and ultrasound imaging. So in conclusion, mammography is evolving. This evolution creates new challenges, but there are new technological developments that are coming down the pike that will be very helpful in combating these challenges. And I'm excited for a very bright future, not only for myself as a radiologist, but for, more importantly, our patients. Thank you.
All right, thank you, Dr. Mckellop. Dr. Tung is our next presenter. He is a breast surgical oncologist for Breastlink at Memorial Care in Orange County. He received fellowship training at Georgetown University Hospital in Washington, D.C., and he has an extensive list of publication and presentation credits. Dr. Tung?
Thank you, Stephanie, for that kind introduction, and good morning for everyone who's taking the time this morning to join us. We appreciate your time, and we're happy to be able to offer our time to help educate the community as much as we can. Once again, my name is Dr. Tung. I am a breast surgical oncologist with Memorial Care Cancer Institute at Breastlink. And today I'm going to be talking about management of benign breast disease. This originally was a topic that I had created for primary care providers in the community to be able to give them a talk that can help guide them with patients that they may be seeing and not totally sure about how to counsel those patients based on different diagnoses. But I also realize that this is something that can be very helpful for everyone in the community. So if you have one of these things going on with yourself, then at least you'll be empowered to have a little bit more knowledge about the topic before you present with your primary care physician or even a breast surgeon if you've been referred. So let's go ahead and get started with the management of benign breast disease. So today I'll be talking about breast pain, breast abscess or breast infection, as well as the management of benign lesions and high-risk lesions. So breast pain is a pretty common complaint in women of all ages. It is most common in premenopausal women. However, those are not the only patients that I see. I see patients in all age groups that present with breast pain. Usually it's cyclical in nature, especially in those premenopausal women, and usually due to hormonal changes. But again, this is not always the case. One of the most important things to think about in patients who present with any type of breast complaints is, of course, ruling out malignancy, making sure that there's nothing suspicious in the breast that could be causing the breast pain. You want to do that with imaging, physical exam, and other routine workup. Generally, breast pain is not the first sign of a breast cancer. However, I have patients who all know somebody whose breast pain was the first sign of something worse going on, which led them to get imaging and tends to find a lesion there. That I think is more coincidental than actually causative. So some of the things to consider in patients who have breast pain, consider trauma. Has there been anything that happened to the patient's breast that may be causing that pain? Is the patient pregnant, breastfeeding? Is there any infection going on? Patients with larger or heavier breasts, psychological stressors, etc. There are multiple reasons that can cause breast pain, which makes it tough for the breast surgeon because generally there's not one thing that I can wave my magic wand for and be able to make that breast pain go away. So what do I recommend? So first, after I rule out any specific cause that I may think is causing it, such as trauma and some of those things I mentioned before, we go over some breast pain reduction strategies. One of the most important things to ask patients is if they're wearing an appropriate fitting bra. A lot of women are wearing bras that are sizes that they've been wearing for years and haven't actually gone out again and remeasured their breast to determine if they actually are wearing the most appropriate bra. So making sure that a patient has a well-fitting and supportive bra is important. A lot of times patients will have bras that support fashion over function. For women who have breast pain, we want to kind of flip that and we want to find something that's more functional than fashion. Another huge contributor of breast pain is caffeine in the diet. Usually the recommendation is to eliminate caffeine in the diet. I don't really recommend that because I feel like patients aren't going to listen to me if I tell them to stop drinking their coffees. So what I recommend is a reduction in caffeine intake. If you're drinking 1 cup a day, try drinking half a cup a day if you're having breast pain. If you're someone who drinks 4 or 5, it's a little easier to cut that down. But generally, I recommend cutting whatever your caffeine intake is into half and see how that helps. If you're someone who can go without that caffeine for a week, give that a shot and see how that reduces your pain. For the most part, my patients generally experience a pretty good decrease in pain by simply decreasing the caffeine in their diet. Other things that are important for patients with breast pain: maintenance of a healthy diet and a healthy weight. Routine exercise is also very important. It can also reduce the incidence of breast pain occurring in women. And if you're a smoker, that is also a contributor. Smoking cessation, not only for breast pain, but for a slew of other issues that smoking can cause, obviously. We always recommend quitting smoking when possible. And if you are one of these patients who is struggling with quitting smoking, talk to your primary care physician. There's a lot of resources that we have and that we can offer to you so that we can help you kick the habit. So some other things that can help with breast pain: breast massage with or without topical analgesics, basically pain relieving cream, can help when you're doing these massages, especially if the area is tender. But by doing breast massage, that's something that can definitely be beneficial. It's not something that's necessarily going to get rid of your pain overnight, but like several of these strategies, it's something that's more of a long-term strategy. Another thing I recommend to my patients is vitamin E, 400 units a day. It may take about a month for the effect to take place for the the breast pain reduction effect to be noticed. So if you don't feel it right away, again, give it some time. 400 units a day is about the max that we recommend. One of the big things that I've noticed as well for patients is reassurance, letting patients know that generally breast pain is not a harbinger of breast cancer. Of course, again, as I mentioned earlier, I'm always going to do imaging to rule out some sort of underlying suspicious lesions. But it's important for patients to know that generally, if you have breast pain, there's not a breast cancer there. And a lot of times, just that reassurance can decrease breast pain in women as well. And again, isolated breast pain, rarely a symptom of malignancy. All right, so the next topic I'd like to talk about is another common complaint that patients present with: breast cellulitis or abscess, basically an infection of the breast, either the skin or the tissue deeper in the breast. Generally, when you have a patient who presents with just redness of the skin, a skin infection, we do recommend antibiotics. Some of the details there are a little bit more important for your primary care physician or the prescribing doctor, but there is something to note that if you are someone who is at risk for MRSA, which is methicillin-resistant Staph aureus, then you want to use different medications than someone who may not have a risk for MRSA. For instance, someone who's never been in a hospital and hasn't been exposed to MRSA, you can use different medications. But again, this is something that's probably more important for your primary care docs. Rarely, we will consider IV antibiotics, which will require hospital admission. Generally, that's reserved for patients who have systemic signs of infection. Maybe you have a tender, swollen breast and also have a fever or other signs and symptoms that would be worrisome for an infection that's spreading outside of the breast. One thing to note, though, is if you have a true abscess, which is a walled-off area of tissue in the breast that has pus in it, the antibiotics are not going to have a lot of effect on that purulent fluid inside the cavity. So generally, for those situations, the abscess has to be drained. And in a lot of situations where the abscess is the main problem, simple drainage of that abscess is enough. And for most patients, even antibiotics, once the abscess is drained, are not necessary. Quite frequently, antibiotics are prescribed to deal with the cellulitis itself. But it's important to note that if you do have a tender, swollen mass that feels soft, like there might be some fluid in there, keep in mind that that's something that needs to be drained. And generally, for abscesses in the other parts of the body, we generally just cut the abscess open and literally leave it open to drain. However, that can leave a pretty unsightly scar. So for patients who have these types of infections in the breast, for obvious reason, we don't want to have an unsightly scar. So generally, imaging guidance with drainage of the abscess is recommended, and we will perform that multiple times if necessary before going to a more formal surgical incision and drainage. And this can be done in the office. This can be done either by the surgeon or by the radiologists. It's pretty straightforward. and pretty well tolerated. And again, incision and drainage is usually usually reserved for more severe cases or cases that are persisting after multiple needle-guided aspirations. Another important topic is for those patients who are breastfeeding. Lactational mastitis is one of the more common causes of cellulitis of the breast. And it's important to note that if you have an infection on the side of a breast where you're doing breastfeeding, it's important to note that it's okay to continue the milk letdown. It's okay to continue to breastfeed or pump. Actually letting that milk out will help the process. If that milk gets backed up, that can worsen the process of the abscess, that can actually make the infection potentially larger. There is an entity called granulomatous mastitis. It is an entity that mimics an abscess formation. They tend to be patients who are presenting with abscesses that recur. They keep coming back after multiple incision and drainages. Sometimes they're even taken to the operating room for surgical management, but the issue keeps getting worse. So these tend to be patients who have recurring symptoms over a greater period of time. These tend to be younger women. So that's something to kind of keep in mind. If you've suffered abscesses that keep recurring, it may not be an actual infectious process. It may be a process that's more inflammatory in nature, which is your own body attacking a portion of the breast and overreacting in a way that's creating a process that's similar to an infection in the breast that may be bacterial, that can cause an abscess similar to that. But again, in all cases, it's important to make sure that what you're dealing with is in fact just an infection or inflammation and not an underlying cancer. So next, I'd like to talk about some benign breast lesions. One of the most common lesions that I deal with in the office that are benign are breast cysts. These are fluid-filled lesions in the breast that can be soft, they can be firm, they can be painful, they can be painless. These are generally assessed pretty easily by ultrasound, and the ability to visualize them under ultrasound also allows us to be able to aspirate them under ultrasound guidance with the needle. So if you have a cyst that's large, that's causing you pain or discomfort, or if you go for your screening mammogram and they notice a mass, ultrasound shows a benign cyst and it just bothers you, you don't like the idea of there being a lump in the breast, whether it's benign or not, you can see the radiologist or myself or another surgeon, and we can aspirate that cyst under ultrasound guidance. And it's an in-office procedure, pretty straightforward. And here's some examples of cysts. This is an ultrasound showing a nice round mass in the breast with pretty smooth margins, as you can see here. And this very dark color in the middle is how the ultrasound sees clear fluid. Basically, it passes through this area very quickly, not bouncing off anything, creating a shadow because there's nothing but fluid in that lesion. That would be called a simple cyst. The next slide is a cyst that we would consider more complex because, as you can see here, it's not as clear, it's a little cloudy. These cysts also can be benign. There may just be debris there in the cyst that makes it a little bit more cloudy. But again, as you can see, smooth for the most part down here, you can see some smooth borders. Maybe not so smooth up here, but this was in fact a benign cyst. Another common lesion that presents in women, especially younger women, is something called a fibroadenoma. This is a fibroepithelial lesion that does not require routine excision. It can cause discomfort for the patients. They can cause cosmetic changes. This is a lesion that, unlike a cancer, it doesn't grow into the breast, it displaces the breast tissue. So if you have a fibroadenoma that's closer to the skin, it can cause a cosmetic defect that some patients don't like, whether or not there's pain associated with that. So if a patient comes to me and has pain or doesn't like the way it looks, then I'll definitely offer to excise it. But for patients who have one of these lesions that are growing rapidly or over 3 centimeters, those are lesions that I would tend to recommend excision. And some of the other things I noted there on the slide are for patients who actually have had a biopsy of the lesion, and some of these comments are mentioned: stromal overgrowth, or increased mitoses, nuclear pleomorphism, lesions that favor phylloides tumor. Phylloides tumor is a rare tumor that can be malignant. Generally, they are benign, but there are some features of fibroadenoma and phylloides that can sometimes it'd be hard to differentiate on a needle biopsy. And in those cases, removing the lesion to prove that it is not a phyllodes is sometimes recommended. So as everyone loves pictures, here's a picture of a typical fibroadenoma, smooth borders. Generally, these feel like soft rubbery masses, but as you can see, a pretty homogeneous internal echo from the ultrasound in this lesion. Looks kind of like a snowy picture on on TV channel 3. But as you can see, well circumscribed margins. So it doesn't look suspicious. These are benign lesions. Another lesion that I'd like to talk about is a papilloma. Papillomas are a very common cause of nipple discharge in women. And generally nipple discharge is benign, and usually the lesions that are causing it are benign as well, benign papillomas. These tend to be mass lesions of larger ducts. They're often underneath the nipple areolar complex. They commonly present with nipple discharge on the same side. Frequently, these can be bloody. Actually, the most common cause of bloody nipple discharge in a woman is a benign papilloma. So although concerning, it's important to note that generally these are benign. And when they're biopsied, if there's no atypia, and by atypia, that is a pathological finding where we can see if the cells on the microscope look typical, that they appear to be a normal type of cell, or do they appear atypical? And when we see those atypical lesions, that's when we worry a little bit more about the potential for an underlying malignancy. So definitely when we see the word atypia, we want to remove those lesions. But in general, if there's no atypia noted, the risk of associated malignancy is very low. Observation for these patients is safe, and especially when the lesion is removed entirely by the core needle biopsy, which can happen quite frequently. So that's something that we look for as well. Was the papilloma transected by biopsy, or was it removed in entirety? And if it is totally out, then it's definitely something that we can consider observation for, but also surgical removal of it is also a very reasonable approach. So if you see here, again, some pictures showing a papilloma there on the left and MRI on the right showing a lesion behind the areola that was also a papilloma. Again, these are benign lesions, unless there's something there more suspicious that makes us want to investigate further with more tissue, and generally more tissue means surgical excision. There's another lesion which we refer to shortly as PASH. This is pseudoangiomatous stromal hyperplasia, totally benign lesion, but it can look pretty scary sometimes on imaging, or even something that you feel in the breast that feels suspicious. There are no characteristic radiology or exam findings that can tell us that, oh, this is PASH, we don't have to worry about it. We do need biopsy to prove that. Generally, this is noted as a developing mass or asymmetry on mammography. And if the diagnosis after biopsy is concordant, which means that the radiologist agrees that the pathology findings make sense with what they saw on imaging, then generally no further excision is required. I'll generally recommend excision for those patients who are having symptoms, it's painful or it's growing in size, or if the radiologist tells me that this is a discordant lesion, meaning they don't agree with what they see on pathology. They feel like the pathology is showing something that is more benign than what the imaging demonstrates. And in those cases, I will recommend complete excision so that we can get a better pathologic analysis of that lesion. And again, you see here two totally benign lesions, but as you can see on this imaging, they look like something that is suspicious and clearly different than the surrounding tissue. So obviously these are lesions that we want to biopsy and prove are not malignant. And if they in fact are benign, then we potentially can leave them alone and follow them up with serial imaging. Next, I want to talk about some high-risk breast lesions. I touched on that a little bit when I talked about atypia. We'll go into that a little bit more. There are some other lesions called radial scars, or more broadly known as complex sclerosing lesions. These are generally identified incidentally at the time of a core needle biopsy for some other suspicious mass on imaging. The risk of malignancy in these tend to be around 10%. So that means 90% of the time, these are not going to be a cancer. However, given the fact that there is a risk of there being an underlying malignancy associated with these lesions, we do recommend excision to prove that there is nothing else going on there. Some things that can be associated with an upgrade risk older patients, how it looks on imaging. Sometimes the radiologist can determine something looks a little bit more suspicious or less suspicious depending on its architectural features, the size of the lesion, and how much of the tissue was actually removed with the biopsy. How big was the needle? Did you get a lot of samples? If it was not sampled well enough, then the worry that there's something else there is higher. Whereas if you have a lot of samples from the biopsy and they're all kind of showing the same thing, no malignancy, no atypia, then it's a little bit more certain that there is a benign process here and probably less likely for there to be a malignancy. Most of the time we do recommend excision, as I mentioned, because of that risk for upgrade. But again, as I mentioned, small lesions that have been well sampled and potentially removed with the biopsy and with imaging and pathology concordance, I feel that it's reasonable to follow those with a patient who's motivated and is reliable in regards to coming back for that follow-up imaging. So as you can see here, this is a sclerosing lesion, a complex sclerosing lesion. You can see there in the middle, it has this kind of stellate appearance. I know many of you are not skilled in looking at mammograms, but if you see the other surrounding tissue, this has a characteristic appearance that is suspicious. All right, now getting into atypia. So when we talk about lesions of the breast, especially cancers, we're generally referring to two entities in the breast. One, the lobules, where the milk is produced for the baby, and then also the ducts, where the milk travels from the lobule to and out the nipple. And there is a lesion that we can find on biopsy called atypical lobular hyperplasia, as well as atypical ductal hyperplasia, which I'll speak about in a minute. There is an increased risk of malignancy in these patients, but we have learned now that the risk is actually pretty low, probably less than 5%. Nowadays, I really only recommend excising atypical lobular hyperplasias in the situation where the imaging is discordant, where the where the radiologist thinks that there may be something more going on and potentially the biopsy did not capture the most suspicious part. But in these patients who do not undergo excision of the lesion, we do recommend close observation with serial imaging and clinical breast exam. Even for those patients who do have the lesion removed, the fact that they've had this lesion, it does pose a it's a marker basically for an increased risk of breast cancer on either side, not necessarily just where this lesion is, but in general. There is an increased risk of breast cancer that the patient should be aware of and should be offered increased screening. The next step up for an atypical lobular hyperplasia would be a lobular carcinoma in situ. And this is an entity that, although with the name carcinoma in its title, sounds like it's a cancer, but we've actually moved away from that. And now we realize that this is actually, again, like the atypical lobular hyperplasia, these are more markers of increased risk, but not necessarily a precursor for malignancy. Especially when we see these classic type LCIS, they generally can be observed as long as the radiologist agrees that what they found on pathology matches up with what was seen on imaging. Classic type LCIS, pleomorphic type LCIS, these are terms that the pathologist will use once reporting the biopsy. Patients with a pleomorphic type of LCIS or those with LCIS with necrosis or other non-classical findings, such as high-grade cytology. These are patients that we tend to treat more like a ductal carcinoma in situ, better known as a stage 0 breast cancer. And for those patients, we do offer excision and we try to go for margins similar to that of DCIS, which would be 2 millimeters. However, there is no optimal margin known for LCIS. And that's something that I think is important to note. And I touched on this, but lobular neoplasia in general, the atypical hyperplasia, the carcinoma in situ, routine excision is not really recommended anymore, especially when radiological and pathological concordance has been demonstrated. Observation's okay, I feel, in small volume lesions that do not have atypia and do not have other high risk features present. So now one of the atypias that we worry the most about is the atypical ductal hyperplasia. Now, as I mentioned, the ducts are what the milk travels down from the lobule into the nipple, into and out of the nipple. And most breast cancers do occur in the ducts. So those patients who have an atypical ductal hyperplasia, and essentially what this means is in the duct, you have additional cells that are atypical and generally would not be expected to be found there. So hyperplasia refers to more cells than you would normally expect in that environment, which can be totally normal. However, the addition of the word atypical tells us that those cells now don't look the way they should. Not only are there more than there should be there, they also don't look the way that they should. These lesions have a risk of upgrade to ductal carcinoma in situ or even invasion up to about 20% of the time. So 1 in 5 women who have one of these lesions, when they have them surgically removed, will be upgraded to at least stage 0 cancer. These also increase your risk for a future breast cancer pretty significantly. So even if we were to go in and remove this lesion and you're one of the 80% of the women who don't have a cancer there, that doesn't mean you're out of the woods, unfortunately. It means that you are at high risk for a future breast cancer and you should be screened appropriately. For these cases, surgical excision is always recommended and always should be offered. And you can also consider consultation with a medical oncologist for risk reduction in regards to that future breast cancer risk that I mentioned, and potentially chemo prevention. Some patients will present to me who have had an atypical ductal hyperplasia diagnosed maybe 6 months, 1 year, 2 years prior, and they come and the recommendation is still for excision because of that upgrade risk. However, after a long period of time with repeat imaging showing stability of the lesion, the likelihood of there being underlying malignancy is much lower. So for those patients who are not interested in surgery and have already had imaging demonstrating stability of the lesion, I feel a little bit more comfortable in offering that observation, but it's also always important to note that surgical excision is still recommended despite stability of the lesion. So that's it. Thank you everyone for your attention. We will have a chance for Q&A at the end. So once again, thank you everybody for your attention.
Thank you, Dr. Tung. Our final presenter is Dr. Bhavana Pathak, who is a general oncologist at Breastlink at Memorial Care in Orange. She has fellowship training in oncology and hematology from the University of California, Irvine Medical Center in Orange. Dr. Pathak has authored multiple research publications and has presented her work at many prestigious national conferences, with much of her studies focusing on wellness and resilience. Dr. Pathak?
Thank you, Stephanie, for that kind introduction. My name is Dr. Bhavana Pathak, and I'm a medical oncologist. And today I'm going to be talking to you about lifestyle factors for optimal breast health, or in other words, what can you do to help reduce your risk of breast cancer? I'd like to start with an overview. First, in terms of what breasts mean to us, briefly looking at the incidence, touching upon a new term we call survivorship, and then going back to some of the basics, what is breast cancer, which helps us understand some of the potential risk factors in the spectrum of risk factors, and finally stratifying these risk factors by evidence level. So first, in terms of what do breasts mean to us, while breast cancer can certainly rarely affect men, breast cancer is a particularly poignant disease of women, especially as breasts are so central to our identity, what it means to be feminine. Here I have two artistic depictions. The one on the left is a sculpture by a local artist, Sherry McEwen, where she's actually portraying the experience of her aunt who had an intellectual disability and in her 70s developed breast cancer and had to have one of her breasts removed. And she described the totality of her entire experience with breast cancer in 3 words: I miss it. And so you see here the replacement of her breast with a square figure. And so it just sort of gives you a sense of the impact it has to go through an experience such as breast cancer. Along those lines, in the lifespan of a woman, breasts certainly play a central role in feelings of maternity and motherhood as you feed your young offspring, and this sort of tree of life that you see here depicted on the left. And on the right, we have sort of mythological, historical representations of the role of breastfeeding and has played throughout our sort of existence as humans. Now, in terms of breast cancer incidence, I think the take home is that it's very common. Many of you may have heard that 1 in 8 women in the US will develop breast cancer in her lifetime. And so while this might be startling, I think the next slide here is a testament to how far we've come. Surviving breast cancer is ever so common now, especially early stage breast cancer. And this survivorship is really a topic of intense interest in recent years. And what does that mean? Survivorship meaning after you've gone through the experience of having the cancer, going through the diagnosis, getting through the treatment, and what it means for your life beyond that. And certainly you as a person and you as a patient are at the center of that, and with all the concerns that come with that. Well, will my cancer come back? Will I be able to go back to work? How will this affect my relationships? But I think an important thing to remember is that you're not alone in this. You know, as we have here at Breastlink, a team of doctors, nurses, surgeons, psychologists, nutritionists, nurses, techs, everybody here is basically here for you and trying to ensure that you not only get through the diagnosis and treatment, but also can enjoy the aftermath and surviving. So now going back to the basics, what is breast cancer? And really need to understand that to understand how we can potentially prevent breast cancer in the future. So cancer is essentially a collection of cells that are growing abnormally or without control, and what we recognize eventually as tumors. And these tumors can be benign or malignant, or what we term cancerous. And the benign conditions Dr. Tung had touched upon. What a lot of women worry about are the hereditary predispositions to cancer. And truthfully, this only actually accounts for about 5 to 10% of breast cancer cases we see. Many more women come to me saying that they've never, they don't have anybody in their family with breast cancer. And so, to understand that breast cancer can be spontaneous. And what we mean by that is that throughout your life, there are changes in your body at the cellular level, or the DNA, the information packets that lead to cell development and growth, and these can become damaged or the repair can be impaired. And that is what leads to abnormal cellular growth. Now, in this slide, which is very busy, but really contains a lot of information on the different risk factors and potential preventative methods in addressing breast cancer. And to look at it sort of at a bird's eye view, going from left to right, we're really seeing the controllable risk factors develop. So on the left, there are things that are sort of out of your control. And as you progress, they become more and more sort of within your reach. And so to start with, breast cancer is much more common in women than in men. And we certainly may not have control over that. And certainly as you get older, the incidence of breast cancer increases. As I mentioned, hereditary factors, about 5 to 10%, you can't really control your genes. And along those lines, when you go through menarche, having an early menarche or menses before the age of 12 can be considered a risk factor. Now, other factors that can also been thought to contribute to the development of breast cancer include having no children, giving birth at an older age after the age of 35, not breastfeeding can potentially put a woman at higher risk. And also going along the chart, having any family history of any type of cancer, where it may not be breast cancer, but a family member with colon cancer, pancreatic cancer, or brain cancer, or leukemia. These types of things are relevant to bring up with your doctor because they can affect your risk of developing breast cancer. Now, going through menopause at a late age, over the age of 55, can also be associated with this, using hormone replacement therapies to treat menopausal symptoms. And finally, as we're going towards more controllable things, using hormonal birth control methods, eating lots of processed and fatty foods, lack of exercise, obesity, and well, this one may not be in your control, but it's just something to know, having radiation therapy in the chest area and exposure to radiation. So all these things, the few methods that we know that can be helpful in preventing breast cancer, which we'll discuss as well more fully later, include things such as, at the bottom, exercising, maintaining a healthy weight, and limiting alcohol intake. So now I'd like to stratify a lot of these risk factors into sort of evidence-based level. So what we know has an association, a strong association with breast cancer. And then what we may consider to have maybe weaker associations, both in terms of preventing and causing. And then finally, factors that we definitively think do not have an association with breast cancer. And these are based on sometimes large scale studies or sometimes small scale studies, but overall better than what we might digest from the pop culture or reading things online, which are not really great sources of truly evidence-based understanding of what the risk factors are for developing breast cancer. So as I mentioned before already, some of these things, such as increasing age, female gender, Caucasian race, body fat, which I've bolded just to highlight things that might be under your personal control. Having a tall stature, estrogen levels, higher estrogen levels, having dense breasts, having higher bone mineral density, having exposure to hormones such as androgens and hormone replacements, having excess insulin levels, long periods of menarche, meaning your total lifespan of having your period, nulliparity, meaning having no children, or multiparity, having many children. Having a personal history of breast cancer also increases your risk for developing breast cancer. Having a family history, genetic mutations, and then, as we'll talk, alcohol, smoking, night shift work, ionizing radiation. These are all factors that we think have been associated more strongly with developing breast cancer. Now, in terms of factors that are associated with being protective against breast cancer, this includes breastfeeding and certainly being physically active. Now, the next slide here goes over risk factors that have, or factors, lifestyle factors rather, that have more inconclusive evidence. And some of them I've highlighted or I've starred or italicized because there might be more emerging evidence. And so, anytime you pick up a magazine these days, they're sort of touting a new sort of fad or diet that can be protective. And so a lot of these are sort of the controversial realm. And so, we don't have conclusive evidence behind the Mediterranean diet or soy. I get a lot of questions about, soy and things called phytoestrogens or plant-based estrogens and their relationship to breast cancer. And the truth is that the jury is out because when we've done studies in an Asian population, which may take in a lot of soy in their diet, there is some evidence that this type of intake could be protective against breast cancer. However, when these studies were replicated in the Western population, it wasn't as clear that it was necessarily protective. It was a little indeterminate. So that's sort of the stance we have on soy at present. Fruits and veggies, and I highlighted this because it's sort of common sense that if you're taking in more fruits and veggies, you're probably taking in less processed high-fat foods. And there is emerging evidence that a plant-forward, whole food-based diet, can be sort of anti-carcinogenic And so it's generally just common sense to kind of include more of these in your diet. Fat intake, still a little bit, in terms of healthy fats, that's still controversial. Red meat, I highlighted that because, the WHO recently categorized processed meats as a, class 1 carcinogen. And so it is certainly something to keep in mind, maybe not necessarily with breast cancer, but, certainly other types of cancers like colon cancers, et cetera. There's still emerging evidence that may suggest that a lot of these processed meats, a lot of this red meat may, unfortunately, be increasingly, we may have increasing evidence that it could be associated with cancers. Now, other things that are a little indeterminate, living in the Northern Hemisphere, getting diagnostic radiation, and then things like bisphosphonates and phthalates in terms of causing breast cancer, and a little indeterminate. And then now calcium and vitamin D, antioxidants, anti-inflammatories, these are also sort of inconclusive in terms of their protective effects in relationship to breast cancer. Now, finally, this is a list of things that we know are not associated with breast cancer, at least based on the studies we've conducted to assess that. And so this includes things like abortion and, along those lines, tubal ligation, cosmetic breast implants, other things, specific chemicals like dioxins and pesticides. While they may not be healthy necessarily to intake, at least in terms of breast cancer, it's not clear that they are causative. I mentioned, I guess, caffeine, electromagnetic fields, electric blankets, and often I get a question about hair dyes. So far as we know, there's no known association there. So a lot of information, but I like to just summarize it in pictures of the lifestyle factors simplified. First, limiting alcohol intake, and I've mentioned this a couple times. And the reason I mentioned this is because there's increasing evidence that there's a direct relationship between the amount of alcohol you intake and the recurrence risk of breast cancer. And so, there's certainly something important to keep in mind in terms of considering your risk for developing breast cancer, and also just to keep in mind some sort of what we consider norms. And so if, consuming a glass or two of wine nightly, especially if you have other risk factors for breast cancer, is actually might be too much. Some recommendations are saying less than four drinks a week. And so that's important to keep in mind, that alcohol is a modifiable risk factor. It's something you can control in terms of your risk for developing breast cancer. The other two things here, again, common sense, maintaining a healthy lifestyle. So exercising, keeping physically active, and consuming a diet that is, limits processed foods and more geared towards whole foods and plant-based foods. And finally, I have a picture of a woman getting a mammogram on the bottom right, and that's just harkening back to the fact that you really just getting plugged in into your screening mammograms, and being in touch with your doctor to make sure that is a part of your lifestyle and your prevention strategy. So in summary, I think we all can understand that breast cancer is certainly very personal and yet still very common. I think it's a wonderful thing that we've entered an era where we're focusing now a lot on survivorship and what it means to come out of an experience of having had breast cancer, or even going through it. It's just, it's something that involves a team approach of, doctors, oncologists, medical, surgical, radiation doctors, radiologists, nurses, genetic counselors, support groups, nutritionists, and at the center of all of that, you. And so, you being the steward of all of this, can decide what you'd like to do, both in terms of medically, and I want to, emphasize that while it's certainly very important to engage in these lifestyle risk reduction factors, they are not a substitute for, the medical advice and prevention strategies that your doctor and treatment team will be discussing with you. And that can include anything, from medications and routine imaging, things like that. And so it's really important that you stay in touch with them. But in terms of what you can do, I think it's also important to keep in mind amidst the sort of muck of information out there in the world nowadays, what is really evidence-based, meaning what do we as clinicians and doctors see as true associations to help reduce your risk of developing breast cancer in the future. And so they kind of boil down to a few things, which is maintaining your weight, being physically active, having a healthy diet, and limiting your alcohol intake. So thank you very much for your time, and I look forward to answering your questions later.
Thank you, Doctors Mckellop, Tung, and Pathak. We do have some questions. I'm going to start reading the questions that have been typed into the chat. I have a question. I'm going to assume this is for Dr. Tung. The question is, can you talk about fat necrosis post-radiation?
Yeah, absolutely. So fat necrosis is something that can occur really with any trauma to the breast. You don't even need surgery to have some fat necrosis occur in the breast, but it is very common after radiation, and again, very common after surgery. A totally benign entity, but it can be very concerning because these can present as a mass in the breast, much like scar tissue of the breast. But generally, and Dr. Mckellop can back me up here, that these are lesions that can be identified on imaging a good number of times, and whenever there is something more suspicious, we can offer biopsy. But generally, these are totally benign lesions that don't need any management at all.
And on imaging, fat necrosis is frequently referred to in radiology as the great mimicker. It can mimic just about anything in the breast, benign or malignant. It is common after surgery, and as Dr. Tung pointed out, any trauma to the breast can elicit this phenomena. Basically, your breast is composed of fat and fibroglandular tissue. Whenever the blood supply to the fat cells within the breast are disrupted in any way, those cells die and they take on this fancy term necrosis or fat necrosis. And there can be some prototypical or textbook classic features on imaging where we can look at it and say, this is definitively benign fat necrosis, but it exists on a spectrum, and sometimes it can mimic disease. So unfortunately, we have to work up some of these cases, sometimes with biopsy, to confirm that it is in fact benign fat necrosis.
Thank you. This next question is for Dr. Tung, and you did sort of touch on it in a previous question. The question is, at what age should I speak with a breast surgeon or oncologist regarding my risk for breast cancer?
That's a very good question. I feel like it's never too early to be aware of your risk. There are certain ages at which it may be too early to consider screening. For instance, patients who are at very high risk for breast cancer and are age 25, we may consider starting screening breast MRIs at that age. However, I don't feel that you need to wait till that age to determine your risk. I think the earlier you know your risk, the earlier that you can empower yourself to employ some of those preventative strategies that Dr. Pathak mentioned, and in general, just being in touch with your doctor so that when the time comes for you to start that screening, whatever age recommendation it is, then you're ready to do that and you're not behind the ball on that. So I always recommend sooner is better. Generally, I'm seeing patients who are in their 20s at the earliest, but if you have a strong family history for breast cancer and you want to be proactive, any age I think is a good time to come in as soon as you start having those concerns.
Okay, thank you. Dr. Pathak, this one is for you regarding something that you mentioned. The question is, why would night shift work be a factor for breast cancer?
That's a great question. I think we're still figuring out the exact mechanisms. However, there is certainly, when we think of the body's circadian rhythm, or the natural rhythm the body has going, from day to night, when we invert that,
there can be a lot of disruptions in the chemical activities or the metabolic activities of the body. And so this can potentially, especially when we think of nighttime as a time for body repair, cellular repair, when that is sort of inverted and missed at the sort of natural time for humans to fall asleep, I think that is, one of the reasons why we might be seeing, signals of increased breast cancer incidence. So I think it's basically the disruption of the circadian rhythm causing changes in, the body's metabolism and sort of processing of precancerous cells and even cancerous cells that exist at a microscopic level.
That's interesting. Thank you. This question, I'm just going to throw it out there for whoever wants to take it. The question is, this person is a HER2 positive 9-year survivor, did chemo and tamoxifen for 5 years. By choice, she sees her oncologist every 6 months and gets labs done. The question is this lab work enough to detect if the cancer comes back?
I can chime in. So first of all, congrats on making it, past 5 years. I think, you've gone through chemo, you've gone through, it sounds like endocrine therapy. In terms of surveillance, in terms of what we think as oncologists and especially medical oncologists, interestingly, you brought up lab work. This is a very controversial topic that I talk to a lot of my patients about. With early stage breast cancer, there's not a lot of good evidence that lab work, tumor marker testing is actually helpful in detecting the occurrence of breast cancer. Certainly in more advanced stages, we use these labs as a surrogate for cancer activity. And so even in our Cancer Society guidelines, we actually do not routinely recommend lab work. However, I do have patients coming to me from other oncologists who had this routinely done, and I typically don't want to disrupt that practice, if especially that made you feel sort of more secure. But I just try to educate my patients that it's not necessarily going to necessarily help detect a breast cancer. Now, in other types of cancers like colon cancer, prostate cancer, pancreatic cancers, there's certainly a role. But in terms of your question, is this enough? The good news is that there's a lot of emerging technology now to help identify cancers at an even earlier stage. And so some of this in the pipeline includes things like detecting cancer DNA or ctDNA in the bloodstream. And again, a lot of these are experimental, being studied in more advanced stages of cancers. But I can foresee it coming, shortly into earlier stage cancers, and also monitoring, in surveillance. And so that is something you can talk to your doctor about testing for, or just having a conversation about it, so that when it does become available, that's something you can hop on. But the other thing that's actually very interesting nowadays is a test called the Breast Cancer Index, and it's basically a test we can now use after about 3 years of being on a pill hormone therapy, or even up to 8 years after your initial diagnosis, where we can determine whether or not you would benefit from getting what we call extended endocrine therapy. So beyond the 5 years that we typically recommend, we've found that a portion of women actually benefit from going even longer. This has been studied in the past, but that benefit was thought to be still quite small, only about 5%, 5% benefit. But now we can identify a subset of women that we previously thought to be fairly low risk, meaning had maybe stage 1 breast cancers. Maybe about a fifth of those women end up benefiting from taking that tamoxifen or aromatase inhibitor, the Arimidex, for even longer. So that is something you can talk to your oncologist about. These are emerging things, and so while they have, they're coming up the pipeline in studies nowadays, I think it's something you should talk to your oncologist about.
you. So this next question is about implant replacement. And there is talk about no need to replace unless there is an issue, but others say you should replace after 10 years. And I've actually heard both of these things too. So is there more risk with replacement after a double mastectomy? And I guess what is the facts about replacement?
So I will try to answer that question, not being a plastic surgeon, but I also frequently hear that as well, that they're recommended to be replaced after 10 years. However, after discussion with plastic surgeons, they'll generally say if there's nothing wrong with the implants and there's no concerning findings on imaging, that they can remain in as long as necessary. I think that's more of a manufacturer's kind of generic recommendations, so that patients are aware that implants that they manufacture are generally intended to be in for only 10 years. So I wouldn't worry so much about that time frame. I would be more aware of what is actually happening with the implants that you have particularly. And one way that can be evaluated is through imaging. And some of the imaging that we do can be implant specific. And into the second question about there being more risk with replacement after double mastectomy, I think that the replacement of the implants is going to be far less involved than the mastectomy itself. So the risk, I don't think is going to be particularly higher. Generally the same risk that you would expect for any surgery, risk of infection, maybe blood loss, but in general, it's a pretty safe procedure, pretty straightforward to have that replacement.
Thank you. I have a question here. Wait, let me grab it. Okay, this is for Dr. Mckellop. How often do you recommend someone with a history of breast cancer get an MRI, a breast MRI, instead of or in addition to a mammogram? And is there an increase of radiation from an MRI?
Okay, I'll take the second part of that question first. Breast MRI does not have any radiation whatsoever associated with it. Mammograms are X-ray technology, so that has ionizing radiation. MRIs have no radiation whatsoever, so one should feel comfortable from that standpoint. Although mammograms have such a low dose of radiation that one should feel comfortable having mammograms as well. In terms of the frequency with which one should get MRIs, having been diagnosed with breast cancer, so primary diagnosis with breast cancer brings about a 15% lifetime risk of developing a second cancer, and that puts one at an intermediate risk stratification. Dr. Tung had mentioned earlier 20% and above relative to the average risk population. While this is not a hard and fast recommendation for an intermediate risk person to have MRI screening, studies have shown that there is benefits with an intermediate risk individual in getting routine annual screening with breast MRI. So in this setting, I think it would be beneficial for patients with a previous diagnosis of breast cancer, to have annual screening with breast MRI, and possibly in the sequence that Dr. Tung had mentioned at 6-month intervals with mammogram, in sequence with their mammograms. Again, this is not a hard and fast rule made by the American College of Radiology, but there is data suggesting that women at intermediate risk with a prior history of breast cancer will benefit from screening breast MRI on an annual basis.
Thank you.
Sure.
This question is in regard to breast cancer in men. This attendee says that my husband's father passed away at 44 from brain cancer, a glioblastoma. Their firstborn sister passed away from stage 4 breast cancer at age 44, and his nephew passed at 1 year from a Wilms tumor. Gosh, so sorry. Should her husband get a mammogram along with other screenings? And he's going to be 47 this year.
So that's a great question. You know, I love talking about breast cancer in men. I like to bring awareness to it. I think as men, we assume that we do not have a chance for getting breast cancer. That's absolutely not true, although extremely rare. A lump in a male breast is cancer until proven otherwise. In regards to screening for men, and I'm sure Dr. Mckellop can chime in on this as well. There are no recommendations for screening for men with mammography. The first recommendation I would probably make, and I'm assuming that the sister who had stage 4 breast cancer is a sister of your husband, I would recommend that she, again, she's passed away, but at the time of her diagnosis, I would have recommended genetic testing for her, or potentially genetic testing for other members of the family who have breast cancer, or even in your husband himself. If there's no increased risk there, I would really only recommend self-exams. And if there's something that is found that's suspicious, then certainly we would work that up with imaging. I don't know that routine imaging for your husband is something that I would recommend, though.
And I agree with that comment. There is no established routine imaging for men. There are some genetic mutations that can predispose men to developing breast cancer. And even in those men, there isn't a hard and fast recommendation, although some men are recommended by their providers to get screening mammograms or even MRIs. It's difficult to tell whether or not there is an underlying predisposing genetic mutation within the family here that would predispose one to male breast cancer. Although it's a rare entity, it's something to be aware of. And I think self-breast exams, clinical breast exams are important in this setting to monitor this patient.
Thank you. All right, so this attendee would like to know, why do seromas happen? She was diagnosed in January of this year with stage 2B IDC ERPR positive. She had chemo, DMX with reconstruction and 8 nodes removed, 6 of which were cancerous. I don't know what all this is. Also PLB2. Let's see. She's 12 weeks post-surgery. Her left side swelled up terribly. They had to take out her expander. She just doesn't understand why the seroma happened.
Okay, yeah, seromas can be common, unfortunately, in any type of surgery. Basically, if you're removing a portion of the body, you are leaving a dead space there that allows fluid to accumulate. Sometimes things like leaky blood vessels, leaky lymphatics, things that aren't healing well, they are going to find a path of least resistance. So if there is an empty space there, if that empty space will be filled up with this fluid. Sometimes that fluid collection can become infected. And it sounds like that's what happened in your case. And being in proximity of the expander, you never want to have an infection in general. You especially don't want to have an infection when there's a foreign body inside. So why it happens, again, those damaged tissue that may be leaky, so to speak, will travel to a path of least resistance. So if there is a cavity there, fluid can fill in there sometimes. So we try to close those dead spaces as best as we can. Unfortunately, the way that we do that is, with sutures, and sometimes those sutures can pull out of the tissue. So it's tough sometimes, those seromas, but that's generally the reason why they occur. And generally they're benign, but if they do become infected, it can cause problems like in this patient.
Thank you. Dr. Mckellop, this question is in regard to mammograms, and it's one of the most common concerns that patients have is that regarding mammograms is the pain from the mammogram exam itself. So the question is, if you have any tips to help women reduce the pain that they experience during a mammogram, and also, can you explain why it's important to use compression during a mammogram?
All right, so this is a fairly delicate and complicated topic to discuss. It's a very common complaint among patients that the compression and the mammogram in general is an uncomfortable and sometimes painful procedure. One thing that I find interesting in this setting is that there are some manufacturers of mammogram platforms that have actually taken the compression out of the hands, almost literally, of the imaging technologists and put that compression control and the degree of pressure into the hands of the patient. And when they look at studies looking at the amount of pressure applied by the patient compared to the imaging technologists, it very reliably and reproducibly has increased amount of pressure applied by patient when compared to the technologists. So what this suggests to me is that there is some component of anxiety, tension that's manifested, by the patient during the exam. And I think what's happening is, as the patient's anticipating the pressure, they may tense their chest wall muscle or the pectoralis muscle and pull against the compression of the mammogram, and in so doing, cause themselves more pain. I'm not trying to deflect blame here in terms of the pain or discomfort experienced by the patient, but I do think that that's an interesting thing to note, that when the power is actually placed in the hands of the patients, generally speaking, are more willing to apply more pressure than an imaging technologist would. So I think there is an underlying psychological component to the experience of the mammogram. So anything that we can do, whether it's the environment on our side to make it a more comfortable environment, counseling or coaching the patient through the experience, and even the patient recognizing themselves that some of this discomfort may be under their own control by relaxing that chest wall muscle, then the experience could potentially be a more pleasant and tolerable one for them. To the second question about why compression is needed. So mammograms are the highest resolution imaging studies across all of radiology. We're seeing findings that are on a micron level resolution. And this is very important for small findings like calcifications. Calcifications are like grains of sand or grains of salt that if you will, that develop within the female breast. If there's any blur whatsoever, any motion while that X-ray is being captured, those small findings will essentially disappear from view. So it's very important for us to apply compression and for the patient to remain still during that momentary X-ray exposure to make sure that we get a still capture of the breast without any blurring of the image. So it's important to apply adequate compression and for the patient to remain still during the exposure of the mammogram. But excellent question. Thank you.
Okay, this is gonna be the last question. We're gonna try to wrap it up at 11:30. And this question is for Dr. Tung. This attendee was diagnosed with DCIS, had surgery and 4 weeks of radiation therapy. She had axilla pain even before the diagnosis, but her doctor told her there was no chance for it to spread to the lymph nodes, but no imaging was done. And she's asking, is there really no chance for the DCIS to spread to the lymph nodes, and how can she be sure?
That's a great question. And I think the best way to answer that is to just explain briefly the difference between an invasive ductal carcinoma and a ductal carcinoma in situ. Essentially, the difference there is in the name. Ductal carcinoma in situ is non-invasive by definition. What that means is that the cancer is trapped inside the duct where it's found. So if it's trapped inside that duct, it really can't jump out and travel into the lymph nodes and into, or I should say into the lymphatics and then into those lymph nodes in the axilla. So your doctor is right that it is not possible for the DCIS to spread, given that once it was removed, DCIS is all that was found. And with good margins and with no invasion noted, biopsy of the lymph node is not recommended. Now, to answer the question about being sure, pathologically speaking, essentially, you should feel sure that there's nothing going on there. However, if you feel very strongly about some sort of evaluation of the lymph nodes in the axilla, you certainly can get an axillary ultrasound, which can look at the axilla for any suspicious findings there. And if there is something suspicious there, the radiologist can determine whether that's something that would need a biopsy or not. But generally speaking, DCIS is a entity that is non-invasive, and we generally do not look for lymph nodes. There are very particular situations where we may look at the lymph nodes in DCIS, and that's not because it's a DCIS, it's because it may be high grade or larger, and we're actually in fact worried that there may be some invasion there found on final pathology. And while we're already operating, we prefer to do that biopsy at the time of the initial surgery. But that's more of a rare scenario where we're worried that there's invasion there, and then we look at the lymph nodes, but we are not looking at lymph nodes for DCIS that's purely DCIS.
Thank you. So we do need to wrap it up now. And we apologize if we did not get to your question. And if you would still like to ask one of the physicians your question, you can email that question to concierge@breastlink.com and your question will be answered. So I just want to thank all of our panelists, Doctors Mckellop, Tung, and Pathak. Thank you so much for this fascinating and really informative presentation. And I'd like to let everyone know that if you would like to review this presentation, it will be available on breastlink.com and also on our YouTube channel, Breastlink YouTube channel. So I also would like to thank Breastlink for hosting this special event. And if you're interested in any more information, you can also visit www.breastlink.com. And thank you all for joining us today. Thank you so much and have a great day. Thank you.